Good evening, everyone. Welcome to University of Hawaii Department CME Grand Rounds. I have the honor of speaking to you today about looking beyond monoclonal antibodies for Alzheimer's disease, why we need them, and what's actually available in Hawaii. But today's star is actually our medical students. Andrew, Kyla, Sophia, and Sarah, who is going to be presenting on the research findings. Thank you, Cindy, for helping us and helping our medical students supporting their research, neuroscience research here at University of Hawaii. Next slide. And next slide, Cindy. Thank you. And so Cindy have read you the learning objectives already. So everybody, please, hopefully you will learn something. Next slide. And if you're not mute, I'd like to ask that you mute so we can everyone can listen to the lecture. And these are my research funding disclosure. So if anybody else want to do research and have funding, please tell them to come and talk to me. Next slide. So why do we have monoclonal antibodies in the first place, and why are things why there are so much excitement in this field lately? Well, because if you are like me, who's been in neurology for the last 30 years, when I started doing neurology, Alzheimer's is just one of those diseases. We just tell patients, sorry, buddy, you got Alzheimer's and there's not much we can do. And, and all we had was symptomatic treatment. Even drugs like donepezil, Aricept that you can see down here, rivastigmine on the right, bottom right-hand side, they are what we call symptomatic treatment, treat the symptoms. But what's been exciting for the last, I would say, 6 to 7 years since we started investigating lecanemab and aducanumab back in 2017, 2018 here in Hawaii is what we call disease-modifying treatment that's targeting the biology, not just treat the symptoms. So what biology are we really targeting? Next slide, Cindy. So when we talk about monoclonal antibody for Alzheimer's, we're really talking about targeting the amyloid cascade pathway. So remember that the two big proteins for Alzheimer's are amyloid and tau. So this is one of them, and everybody knows from medical school, you see those amyloid plaque in the brains of Alzheimer's patients. That's that big clump of plaque. But how did the plaque get there in the first place? The basic building blocks are the APP, right on the left-hand side of your slide, amyloid precursor protein. They go through a cascade of events to get to that plaque. So drugs like lecanemab, which I circled there, and donanemab, which are Kisunla, which is the other FDA-approved monoclonal antibody. It binds, they block the pathway somewhere. So lecanemab binds to the protofibril stage at the elongation phase, preventing the formation of soluble fibril into the insoluble fibril stage, while donanemab actually binds later in the stage at the plaque phase. Some of you may actually remember aducanumab or aduhem. Aduhem actually blocks the second phase of the aggregation phase, also circle and the fibril. So basically, the three drugs are approved: aducanumab first in 2021, or aduhem, lecanemab, Leqembi 2023, or donanemab. They like to call it Kisunla. They don't want you to call it Kisunla because they want to be the sun, Kisunla. In 2024, they all works on this amyloid cascade pathway. Next slide, Cindy. So, next slide. Thank you. So, why do we need different treatments? What are the challenges? What's wrong with them? So, to have better treatments, to have better drugs, to do research, we need to tackle a problem. We just want to do research for research's sake. So what's the challenge? The challenge number one is obviously the big one, ARIA, amyloid-related imaging abnormalities. Why the ARIA? Well, what happens is when the monoclonal antibodies, we actually have to give a lot of it into the systemic system, IV, or a little bit of it to get into the brain because of the blood-brain barrier. When you give so much of the monoclonal antibodies in the systemic system, it actually weakens the cerebral blood vessels, increase the permeability. Because of that, there's seepage. So there's edema, the two types of area. This is your learning objective. Two types of area is area E, edema, and area H for hemorrhage. So on the MRI, you see that on A is A and B area edema. You can see the hyper intense signal, among the south side, and C and D are area hemorrhage. Usually the micro hemorrhage you can see, but sometimes it can be serious. So thankfully, most of the area that we have here on Hawaii are not serious, although most of them are reversible. They tend to happen when we ramp up the dose, either from 10 to 15 in lecanemab case, 10 milligrams per kilo to 15 milligrams, they tend to happen. So it is routine that we check the MRI after the fifth infusion, after a certain number of, it's part of our protocol. And luckily, after doing over 50 plus cases of monoclonal antibodies, our rare cases just kind of hovers just under about a dozen. Luckily, most of them are not serious, although I have to say there's one case we actually had a patient who developed permanent epilepsy, permanent seizure, and we did have a case also with a little bit more serious stroke. So they can be serious, but thankfully, most of the time they're not, and most of the time they're reversible. We actually have to hold the infusion. Next slide, Cindy. So what kind of patients tend to have higher risk? So before we actually send them, recommend monoclonal antibody, I'm actually very careful. We check the ApoE4 genetic profile, the allele. We know that patients who carries the E4. So for aducanumab studies, if you're E4, your risk of ARIA, you can see that is edema is 64%. If you have one set of E4, your risk is 36%. For lecanemab, if you're E4 positive, your risk is 14% as compared to E4 negative 8%. Same thing with donanemab. The risk are actually, if you're E4, both sets of E4, your risk is 44% for ARIA. So I get a little bit nervous when I see an MRI that has a lot of small vessel white matter disease. I tend to be very careful, discuss the risk for my patient, and hopefully they understands that. And not to say that they can, with the E4 or E4, but they just have to understand the risk. And every patient is different. If the MRI shows like it's amyloid microvascular changes, I tend to steer them away because I know that ARIA is such a high risk. So what are the symptoms of ARIA? The two most common symptoms are headache and dizziness. Let your patients know, but actually, do the patients usually present that way? No, the answer is no. About 90% of them are actually asymptomatic. So you definitely have to depend on your MRI to check those. Next slide, Cindy, thank you. So that's challenge number one with monoclonal antibody is the side effects, amyloid-related imaging abnormalities. So how do we overcome the challenge? So luckily, there are really smart people that are working in this field, who have thought of very smart. So a company like Roche have already developed a technology called the brain shuttle technology, the novel brain shuttle technology. This is this little molecule on the left-hand side. So remember, I told you that we have to give a lot of lecanemab, like 15 milligrams per kilogram into the systemic system, a little bit of it to get into the brain because of the blood-brain barrier, that barrier. So what do? They attach the brain shuttle molecule to a similar monoclonal antibody called trontinemab. And what happens? The brain shuttle basically shuttles the monoclonal antibody through the blood-brain barrier, whoop, into the brain. So you can see that on the brow below, on the left-hand side is the rat's brain without the brain shuttle. Some of it gets in, but what happens when you attach a brain shuttle to the monoclonal antibody? The brain lights up because everything just gets into the brain in the brain shuttle. Next slide, Cindy. So does it work? So instead of giving things like 15 milligrams per kilogram, we can actually lower the monoclonal antibody down to 3.6 milligrams per kilogram in a clinical trial with trontinemab. Okay, this is a phase 1b trial, and even you can see that on the graph on the right-hand side, even at 3.6 milligrams at the low dose, there's a 91% reduction in the amyloid from the PET changes. So it seems to work, you know. And the exciting thing about what these people are doing, trying to overcome the challenges for real, is so far in the phase 1 trial, we don't see any area edema or area hemorrhage so far. So that's really exciting to me. It's exciting because it offers my patients who are at high risk for area an option. Especially, we have a lot of patients who are on blood thinner, Eliquis, Agrinox. They are just high risk for ARIA. So this is really exciting to me. And we're going to begin this trial in Hawaii later in the year. Next slide, Cindy. What's challenge number 2? Challenge number 2 is that you have to give monoclonal antibody is something that you have to give IV, you know, and you have to give it right now. Leqembi is every other week or twice a month. You know, all donanemab is once a month, you know. So we have a lot of patients that are coming from the neighbor island. Can you imagine having to fly to Oahu every other week for IV for about 2 hours? Would you want to do it at your own expense? And that's a lot to ask of our patients. So of our memory center, we have close to about 2,000 patients here. I would say about 10% of them are from the neighbor island, especially Big Island, Maui, Hawaii, Molokai, and it is really unreasonable to expect them to fly here every other week. So what do people do? So the really smart people, in this case, the Proteina on the mainland, they are developing high affinity humanized another monoclonal antibody, class 1. So what is a high affinity? High affinity means it binds to the plaque a lot better than our current. So you can see on the graph on the right-hand side, this is the ELISA binding of Proteina's next generation drug. It doesn't have a name yet. It's called PRX0012. And it binds, and at that time, when they did the study, everything is compared to aducanumab. It has 12 times the binding affinity. Imagine the drug that binds to the amyloid 12 times. So it stick longer, so you don't have to give it every other week. So when we initially started this clinical trial, guess how often our outer island patients were flying here? Once every 3 months, just for an IM shot. Isn't that great? Instead of flying it every other week, once I see you in 3 months' time. And hopefully in the future, we can develop something that they don't even have to fly here. They can just give it at home shot. Boop, IM shot. So these are the things that smart people are thinking of and working on solution. So convenience, access. Well, we have side effects of ARIA, but we also want to know how do we take care and increase access for our neighbor islands friends. Next slide. So challenge number 3 is why do we need other things other than monoclonal antibodies? The question is, we have beat this horse amyloid cascade pathway for years. I remember as a resident, as a fellow, almost 30 years ago, we've been working on this pathway. Have we made great progress? We made some progress, I would say. Are they great? I wouldn't say they're great. The question is, do we have the right target? So if you look at some of the mechanistic pathway in Alzheimer's, still a lot of drugs are still targeting amyloid, but you see that some phase 1, phase 2 drugs are going to tau. We look at the second, and then inflammation, neurotransmitter receptors. Those neurotransmitter receptors, most of them are actually for symptomatic treatment. So, and then the other promising things is synaptic plasticity, neuroprotection. And I also want to talk to you about some trials that we're doing on bioenergetics, metabolism, neuroprotection. So this is some of the exciting things. Do we really have the right target? Why we need something else other than monoclonal antibody? That's because we can't really put all of our egg into that basket. We need to think outside the box. So let's get right into it. Next slide. So I want to tell so the second thing that people thought about is, okay, all right, amyloid, what about tau? Yes, one of the trial that we're working on is a phase 1b/2 trial. So remember, tau is actually a normal proteins, the skeletal structures. So amyloid is extraneural, outside the neuron. Tau is intraneural, inside the neurons, and they're actually in the skeletons, the microtubules of the neurons. So they're actually good proteins that turn bad. What happens? They get hyperphosphorylated. Then they become that nasty tau. They become the PET helical filaments, or they turn into the microtubule associated protein tau. Those are the tau tangles that we see inside the neurons. So what are we doing? How are we tackling this problem? So so Biogen is already developing a technology called ASO. Some of you may be familiar with ASO. ASO is antisense oligonucleotide. So basically, it develops a complementary antisense drug that binds to the messenger mRNA of the DNA that manufacture the nasty tau protein, and it stops the translation of tau expression proteins. The problem with this drug is it has very poor penetration into the brain, through the blood-brain barrier. So our patients, we have several patients on this trial, actually has to have an intrathecal LP injection every 3 months. So they come in for intrathecal injection every 3 months, and this is an ongoing trial, going well so far. I'm really excited. I'm kind of keeping an eye on our patients. Next slide. So remember, I told you about bioenergetics, metabolism. You may have seen on television, everybody is talking about what? Ozempic, the weight loss drug, right? Everybody's talking about diabetic weight loss drug, Ozempic. So guess what? Alzheimer's folks are onto this trend as well. And we actually have been doing these clinical trials for the last 3 years. So what are we doing? Well, we have known for a long time that Alzheimer's disease patient, the brain metabolism has some similarities to diabetic patients. Diabetic patients have twofold increase of getting Alzheimer's. Almost 70% of diabetic, if you're diabetic, almost always you develop Alzheimer's at some point. 37% of Alzheimer's are diabetic. So there's some common pathway. So we really believe that in the Alzheimer's patients, there's abnormal glucose and lipid metabolism. So what if we change that metabolism, tackle it from the different angle, bioengineering, leave alone the amyloid, forget the tau, let's tackle this. And this is the EVOKE trial, where we've been doing for the last 3 years here. What have we been doing? We have been giving our patients semaglutide. So there's 3 arms, placebo, 7 milligrams and 14 milligrams a day. This is a PO semaglutide. Unlike your weight loss patients or diabetic patients getting the injection, this is a pill that we're giving our patients. So how is that working so far? Next slide, Cindy, let's take a look. So there is now close to about 20,000 patients. This is a Novo Nordisk study based out of the Netherlands. So if you look at the numbers at the bottom, there's 8,000 patients on GLI-1, semaglutide, 8,000 on placebo. We have close to about 20 patients here in Hawaii that's currently in this, actively participating in this trial. So you can see that in the year, so the graph going up is actually dementia. You don't want to go up. Okay, so on the x-axis is the years, okay, being on the trial. The patients on the Ozempic is the blue, and the patients on the gray is the placebo. Okay, so you can see that in the year 1.5 years, there's not much difference. Patients on the drug treatment are on, but starting about year 2 and year 2.5, you're starting to see the split. Patients that are on placebo tend to develop dementia more, and patients on the Ozempic, semaglutide, tends to stay flatter. It's not cured. Some of them still do develop dementia, but you can definitely at year 4, year 4.5, year 5, we see a huge difference. You know, patients on semaglutide are less likely to develop dementia. So do we really have the answer? Is this the holy grail? I don't think so, but it at least tells us that there is a metabolic pathway, there's a bioenergetic pathway that we need to pay attention to. I think we have focused long enough on amyloid, we've focused long enough on tau. We need to kind of reinvest, rethink, think outside the box. There is something that we need to pay attention to. Next slide. Another exciting clinical trial that we will be doing later this year is looking at reducing neuroinflammation and actually getting rid of the amyloid. So far, all the clinical trials that we talk about is trying to prevent the formation of amyloid and tau, right? But what about those that are already there, that's interfering with the synaptic transmission of the neuron? What do we do with those? How do we get rid of them? So let's go back to basic science and think about how do we get rid of garbage in the brain? So your brain actually has a garbage collector, you know, called microglial cells that goes around eating up all those garbage, phagocytosis, eating up all those amyloid. Okay, so the people that are actually, this is actually being used in the oncology field and also in active clinical trials in things like ALS, other neurodegenerative disease. They're thinking, well, what if we could activate this garbage collector? They use a mechanism called TREM2, triggering receptor expressed on myeloid cells 2. It's a transmembrane receptor on the microglial. We activate them and let them go around and eating up phagocytosis, auto amyloid plaque. You know, just basically you're just hiring more garbage collector in your brain. If that's what you want to look at it. You know, so how is this given? This is again a human monoclonal antibody that's IV once a month, and we're going to start this clinical trial later this year as well. Next slide. So last clinical trial, last thinking outside the box besides amyloid is I want to look at is there some neuroprotective synaptic plasticity mechanism that we can look at? Well, we have actually thought about this a long time. Okay, so if you look at all the toxic proteins in the brain that causes neurodegeneration, whether it's Parkinson's and Lewy body, Huntington inclusions, superoxide dismutase in ALS, or amyloid and tangles in Alzheimer's, all of those, why don't we just look upstream, look a little bit further up instead of attacking it at amyloid and tau? Once they get to that stage, look a little bit upstream. So if we look a little bit upstream, we look at the all of this toxic neurodegenerative proteins actually has a common, has a highly preserved consensus loop in the 5' untranscribed region of the RNA, you know, in the messenger mRNA. So if we look, so a company has actually looked at this. Next slide, Cindy. What if we can just bind, again, same thing, stop the translation of this nasty proteins right upstream at the beginning? So we actually looked at this several years ago, about 4 years ago. We conducted this clinical trial on butanetap. It doesn't have, now it has a name, it doesn't have a name back then. So we actually conducted this trial on both Alzheimer's and Parkinson's patients. You know, in Alzheimer's patient, there seems to be some improvement in the ADAS-Cog. and the WAIS coding. In the Parkinson's patients, obviously we test the movement, but more importantly, we actually look at the CSF biomarkers for neurodegeneration, including amyloid, TREM2, neurofilament, neurogranulin. So we look at those that seems to make a difference. So we actually published those in 2022 in Journal of Prevention of Alzheimer's Disease. Butanetap in the publication below, novel translation inhibitor of multiple neurotoxic protein. Could it be safe and promising for both Alzheimer's and Parkinson's? We don't know yet. This is an ongoing trial, and we're going to actually launch into the phase 3 large-scale trial later this year in Hawaii. And we're very lucky to get this. This is an oral pill to try to we don't exactly know what it is, but we're excited to launch into that. Next slide. Next slide, Cindy. So just to summarize, what is available in Hawaii? So just know that this is not the only thing that's available besides monoclonal antibodies, besides MLA. There's hundreds of other pathways, hundreds of other clinical trials that we can look at. But what's the important thing is, what can our patient access? What's available in Hawaii? So these are the active. So for patients, for preclinical to MCI, MMSE22, obviously we are going to have the brain shuttle technology, trontinemab, the IV once a month to overcome the issues of ARIA. We have the tau, CELIA trial, which is intrathecal. Unfortunately, patients has to be willing to undergo spinal tap once every 3 months, and the metabolism bioenergetic semaglutide. For patients that are a little bit further along, MMSE, maybe less than 22, we have the neuroinflammation trial, the TREM2. Again, that is against IV. Remember, that's the garbage collector eating the amyloid, IV once a month. And then we also have the IM injection monoclonal antibody that's coming up, sub-Q. And then for patients that are a little bit further along, we actually don't even need CSF anymore. Right now, the trend is really to go after blood biomarker. For a lot of these trials, we're actually testing phosphorylated tau 127 in blood biomarkers. So I believe in a few years' time, we will not be using PET scan anymore. It is not that accessible. We don't have it in Hawaii. So, but we're going to offer some neuroprotective phase 3 butanetap trial later this year. So I'm really, really excited about this view, about what's coming up. So let's look at next slide, Cindy. Keeping in mind, this is not the only trial. What does the future looks like in this field? Besides monoclonal antibody, just take a look at this overall picture. In 2024, in the Alzheimer's drug development pipeline, there's 164 clinical trials going on. We probably, out of those 164, we have maybe about 15 of them that we've been able to bring to the state, to the island, testing 127 drugs. Majority, about 80% of them, are disease modifying, with 57,465 participants. Thank you to every single one of those participants who are willing to participate, to help us find better options, find better treatment for our patients. On average, it takes 13 years development time. So thank you to every single one of the doctors who are willing to work with us to move the needle, to develop better treatment for our patients. Next slide. I could not do this by myself. We have a wonderful team of neurologists, some investigators, and a whole bunch of medical students that's part of our BRAIN program, Bridging Research and Innovation Neuroscience. They're working with us. With that, I'm going to introduce our next speaker, our student from the BRAIN program. So Andrew, are you going to go next?
Yes, that sounds good.
Perfect. Go take it away, Andrew.
Thank you.
And Kyla.
Hi everyone, my name is Andrew Matias, and I will be presenting this with my teammate Kayla. And our project was on insights into obstructive sleep apnea amongst Native Hawaiian Pacific Islanders on the islands. And we actually didn't look just at Native Hawaiian Pacific Islanders, we looked at different populations that are common here, so Asian, white, etc. And we decided to focus on Native Hawaiian Pacific Islanders in particular just due to the lack of current research that there is on obstructive sleep apnea in particular. So we thought that given Hawaii has such a large amount, I believe it's almost a quarter of individuals here identify as Native Hawaiian or Pacific Islander, it's a great opportunity for us to explore this topic a bit further. So we did find some findings that did agree with current literature out there, such as obstructive sleep apnea is linked to obesity, particularly BMI rates. There was a positive correlation. But we also found some things that were not that were novel according to the current research out there. So what we found was that Native Hawaiian Pacific Islanders actually demonstrate a better adherence according to their peers. So a lot of research out there finds that a lot of minority groups demonstrate not as optimal adherence in comparison to their peers. But we found that Native Hawaiian Pacific Islanders actually did demonstrate better adherence to PAP therapy as the obstructive sleep apnea worsened. So we decided to look a little bit into that. Particularly, we looked into socioeconomic variables, classic ones such as household size, or we looked at education levels, we looked at median household income, but we weren't able to establish any strong correlations or anything significant there. So we decided to look a bit more into the social cultural side. So my teammate Caleb will explain a little bit more about the social cultural hypotheses that we developed from looking at that.
Thank you, Andrew. So like Andrew was saying, we tried to look for socioeconomic factors that would account for why NHPI patients in Hawaii demonstrated higher CPAP adherence rates than their peers, but there weren't much correlation. So this prompted us to consider sociocultural factors, specifically how cultural and familial dynamics might influence adherence in ways that economic data alone couldn't explain. So, Hawaii's housing landscape actually offers a unique context for considering how family support influences healthcare adherence. With housing and utility costs being sky high, it's really no surprise that Hawaii has the highest rate of multi-generational households at 15.7%. Furthermore, NHPI make up the largest share of this pie. Beyond cost sharing advantage to that, these living arrangements can also provide crucial social and health benefits. With multi-generational households, family members can share caregiving responsibilities, such as providing transportation, managing appointments, and even reinforcing treatment adherence. And I think this creates a potential adherence advantage in Hawaii's NHPI patients, which is one that may not be as prevalent elsewhere. And by that, I mean our studies show that NHPI populations showed increased adherence, but studies such as in Utah and New Zealand actually found the opposite, where NHPI populations had lower CPAP adherence. Our reasoning for that is one, the composition of NHPIs in places like New Zealand is more Maori, whereas in Hawaii it's Hawaiian. And another explanation could be that migration related stress and weakened family ties could disrupt the support systems that are more intact in Hawaii. So, again, this supports that family dynamics may strengthen social support, encourage shared decision making, and reduce stigma and logistical barriers to care. Next slide. While socioeconomic disadvantages are often associated with lower adherence rates, our findings challenge that in the NHPI population. So we asked, could strong family networks be a critical factor in supporting CPAP adherence? Research supports this idea. In 2022, a study by Khan and colleagues showed that structured caregiver engagement significantly improved CPAP adherence in newly diagnosed OSA patients. Similarly, in 2020, there was a study by Shu and others, and it found greater family support correlates with higher CPAP self-efficacy and outcome expectations. And although these studies didn't specifically examine the NHPI populations, they provide a compelling framework for our findings. given that Hawaii has a high prevalence of multi-generational households, in addition with just general cultural things like in Hawaiian culture, ohana or family, and then kuleana and responsibility is important. And it's possible that these similar dynamics could be contributing to the higher adherence rates that we observed in the NHPI populations. Slide.
Thank you, Kayla. So that was the sociocultural hypothesis that we arrived at. And I'll just get a little bit more into the nitty-gritty of the actual design that we did in order to arrive to that conclusion. And we split it basically into three phases. So initially, what we found were a bunch of descriptive factors, but thanks to the guidance of our PIs, Dr. Carzana and Dr. Liao, we decided to use comparators as groups as well and analyze the statistical difference between those groups in order to arrive at a more comparative conclusion. So we had 340 sample patients from Hawaii Pacific Neurosciences Accredited Sleep Center, and it was about an even split, a little bit more Asian, but we had NHPI, Asian, and white groups as the comparators. And so next slide, please. So as mentioned, we had three phases. The first phase, we split it between BMI and AHI severity. So AHI severity is the apnea-hypopnea index. It's essentially just a proxy for how severe the obstructive sleep apnea is. So higher score means a more severe sleep apnea. So we found that BMI is a consistent predictor regardless of ethno-racial background. There was no statistical significance between those slopes that we performed. So we did a regression analysis between each ethno-racial group, and there was no significance between them. So this was interesting because it showed that BMI could be a reliable predictor of HI severity, and it also highlights the importance of perhaps targeted treatment at the obesity side, which because a lot of Native Hawaiian Pacific Islanders did present with higher BMIs, so as a result, they did have a lot of a higher obesity rate and obstructive sleep apnea severity. So if we can target it at the obesity rate, then we could have promising results given that they have the same relationship as their peers. So that was the first step. And the second step was very similar. Next slide, please. So similar methodology, but we did the AHI severity and adherence. So from here, we also found something that agrees with common literature. So the higher the severity of obstructive sleep apnea, the more adherent individuals do tend to be. That's just due to likely the therapeutic benefit of adhering more due to lessen the worsened symptoms. But we also found something, and this is where the novel finding was. We found that even though all groups did demonstrate a positive correlation between the severity of obstructive sleep apnea and adherence, Native Hawaiian Pacific Islanders had a notably more improved adherence compared to their peers. So as you folks can see, that dotted line, the steepest slope one, that is the Native Hawaiian Pacific Islander slope, and then we have the other groups as well with white individuals still demonstrating a positive slope, but it's the least pronounced. So this is where we started to think this is really interesting. This goes against common literature and findings out there. There were two other studies done amongst Native Hawaiian Pacific Islanders, but they were done in Utah, and the other one was done in New Zealand. But there was actually no comparative ones done in Hawaii. So we thought that this might be something interesting. Let's look a bit more into the socioeconomic variables. We'll see if we can find something that explains that. So next slide, please. So when we did look at the socioeconomic variables, we pulled it from the US Census Bureau, and then we also segregated it by zip code and based on the population in that zip code according to each ethno-racial group. And what was interesting is we found that there was no really significant correlations between a lot of the commonly predictable variables due to adherence, so median income, poverty rate, employment, education, etc. We did find one small correlation between the employment rate. So it was actually an inverse. So higher employment rate actually had a bit worse adherence. We looked at the literature for this. There were some studies that confirmed this. There were some studies that didn't confirm this. So we decided to keep that on the side for now. Perhaps that's just a spurious finding that we found. But in addition, we decided that since there was no real difference between the high income zip codes or the lower income zip codes, even amongst the same ethno-racial group, we decided that the sociocultural hypothesis would be something worth exploring. Next slide, please.
Yeah, so in summary, BMI consistently predicted OSA severity across all groups. NHPI had the highest severity at diagnosis, likely due to a higher BMI upon presentation. Although all ethno-racial groups demonstrated a positive correlation between OSA severity and adherence, NHPI patients demonstrated stronger adherence than their peers. But this was not adequately explained with the socioeconomic variables that we examined, which led us to suggest sociocultural factors might play a larger role. What this means, we think for clinicians, we do acknowledge that more research needs to be put into this to fully understand the patterns. But first, rather than focusing solely on clinical data, it's important to also recognize the broader cultural and familial context surrounding NHPI patients. Understanding how extended families, cultural obligations, and community networks influence daily life can provide valuable insights into potential barriers and motivators for CPAP adherence. Second, we should be cautious about applying adherence assumptions drawn from mainland or broad minority populations, as it may not apply directly to the patients in Hawaii. As a majority state, Hawaii has a unique cultural landscape, and the local NHPI patients may have different experiences and support systems compared to NHPI communities found elsewhere. And lastly, these observations suggest that family involvement could be an underutilized asset in OSA management. Clinicians might consider more intentional engagement of family members through caregiver education. Moving forward, more qualitative research is needed to explore how NHPI families in Hawaii navigate CPAP adherence and how these dynamics can be integrated into culturally tailored interventions. By moving away from this one-size-fits-all approach and developing more targeted strategies, we might uncover new pathways to enhance adherence and improve outcomes for the NHPI patients with obstructive sleep apnea. I think that's it. Thank you.
Go for it, Sarah.
All right. Hello, everyone. My name is Sarah. Last summer, I had the pleasure of leading a team of undergraduate interns and conducting some research. And one of our stellar interns, Sophia, will be presenting our work today. She actually just recently took her MCAT, which is a major hurdle in medical education. So now she's doing this. Can't wait to see what she does in the future. So take it away, Sophia.
Hi, everyone. So again, my name is Sophia, and today we'll be presenting a study entitled A Multiple Sclerosis Pilot Study, Are There Differences in Spinal Cord Involvement Among the Ethnocultural Groups of Hawaii? Next slide, please. So as you know, multiple sclerosis, or MS, is an autoimmune inflammatory disorder of the central nervous system that produces demyelinating white matter lesions disseminated in time and space. So clinically, MS most often presents with sensory or motor symptoms, but up to 50% of patients develop depression, many experience mood disorders, and a smaller subset can even present with psychosis. So therefore, early recognition of those at risk for neuropsychiatric comorbidity can profoundly affect the quality of life and long-term outcomes. So what piqued our interest into doing this study is that there is research to suggest that when spinal cord imaging is done at initial presentation, the burden of lesions may actually be able to predict the future disability level. So given that we're in Hawaii with an ethnoculturally diverse population, we're wondering if brain and spinal imaging at initial presentation may correlate with disability severity. And because we're already collecting data on all of this, we decided to also look into the demographics to compare comorbidities across these different groups. Next slide, please. So to do this, we conducted a retrospective chart review of the Hawaii Pacific Neuroscience Database of all MS patients from 2008 to 2023, adults above 18 years old. And we collected the demographics, comorbidities, lesion burden and location on both brain and spine MRI, and the presenting expanded disability status scale score, which we'll refer to as the EDSS score. And this score was assigned by a single one of our team members to ensure uniform scoring across all of these patients. Next slide, please. So going into our results, this data was stratified into 6 groups: Caucasian, Hispanic, Asian, Black, Native Hawaiian, and other Pacific Islander, which we'll refer to as NHOPI, and other. And something to note here is that one of our primary limitations is that our subgroup sizes, particularly the NHOPI group, are very small, which limits the statistical power of these comparisons. But overall, we had 128 patients total, majority being female. In our spine MRI group, we had 68 patients, majority being Caucasian. And then in our brain MRI group, we had 67 patients total, and then the majority were also Caucasian. And then this figure on the bottom here shows the age at initial presentation stratified by ethnocultural group. And after post-hoc analysis, we found that Caucasians were significantly older at presentation than the Hispanic group. Next slide, please. And across the full cohort, a few common medical comorbidities included hypertension, hypercholesterolemia, migraines, smoking status, and having an overweight BMI. And then a few of the psychiatric comorbidities were depression, anxiety, and bipolar disorder. However, we saw no significant differences in any of these comorbidities across all of the ethnocultural groups. Next slide, please. We next looked to see if there were any differences in disability status score across these groups at presentation. So this figure shows the presenting EDSS score of each ethnocultural group. And after post-hoc analysis, we found that the NHOPI patients had a significantly higher EDSS at presentation compared to the Hispanic group. Next slide, please. And when we looked at lesion burden on spine and brain MRI, overall, there were no significant differences across the ethnoculture groups. However, we did find some differences overall comparing EDSS versus the number of spinal lesions. So looking at this bottom left graph, when we compared patients with 2 or more spinal lesions to those with exactly 1, the group with 2 or more lesions had a significantly higher EDSS at presentation. And then the bottom right graph shows the number of brain lesions versus the EDSS score, which show no significant differences in the amount of brain lesions and the presenting EDSS score. Next slide, please. So to conclude, we saw no race-based differences in overall spinal or brain lesion burden, but 2 notable exceptions were that Caucasians presented significantly older than the Hispanic group, and the NHOPI group had higher EDSS scores at presentation than the Hispanic group. Genetic factors may underlie the differential age of onset or lesion susceptibility in these groups. And additionally, socioeconomic and historical factors could delay diagnosis or treatment, leading to higher disability at the first visit. In the future, we definitely want to expand our sample size, particularly among the NHOPI group and other underrepresented groups. And it would also be interesting to perform a longitudinal study tracking the EDSS trajectory over 5 to 10 years in patients with baseline spinal MRIs, so that we can truly assess the prognostic significance of early spinal lesion burden. And lastly, because MS commonly presents with depression, anxiety, cognitive dysfunction, and even psychotic features, studying in the future, we definitely want to expand our sample size, particularly among the NHOPI group and other underrepresented groups. And it would also be interesting to perform a longitudinal study tracking the EDSS trajectory over 5 to 10 years in patients with baseline spinal MRIs, so that we can truly assess the prognostic significance of early spinal lesion burden. And lastly, because MS commonly presents with depression, anxiety, cognitive dysfunction, and even psychotic features, studying early spinal lesion burden across these ethnoculture groups is critical to inform proactive psychiatric screening and integrated neuropsychiatric care. And I think that is it. Thank you.